welcoming everybody to the 2024 year in review for clinical research and news, with butterfly technology.
That was great, Devinder. You sounded like Wolf Blitzer. Welcome to our viewers from the United States and around the world.
And Peter and John, I'll ask for your help as I'm sharing the slides here just to kind of monitor how we're doing with our attendee list and chat to be able to answer for any questions that come up along the way. But we'll probably give it just one more minute here to get a group of folks signed on, and then we'll kick this off.
Yeah, and Devinder, would you like them to use the chat or the question tool? And we would encourage them to use whichever one you suggest. Do you have a preference?
I think the question tool is great because it allows a little bit more interactivity, so we can kind of real-time monitor,
Okay, that sounds great.
and give those updates to the attendees.
Yeah, the question tool is probably the best one to have downstream answers as well if we don't get to them all tonight.
All right. All right, I gave it that extra minute here. I have my holiday cup of coffee here. I hope Peter and John, I hope you guys are equally have something there nice and warm to enjoy with. Yep, I see John has his. Peter, that are great. Well, welcome the two of you again for our 2024 year in review, and for the audience, happy holidays, and excited to kind of talk about this webinar. This is always something that I enjoy talking about, obviously from the research lens, and I know both of you as well. And what we try to do at Butterfly right at the end of the year is try to take a recap of what have been some of the main headlines from the research and news perspective out there with our technology. And I would have to say 2024 has definitely been a busy year, right? We've had a lot of, I think, some landmark activities coming out there showing the emergence of point-of-care ultrasound in new care settings, new technologies, and new strategies for education. And so with that, I'll go ahead and introduce myself. Devinder Ramsingh. I'm a cardiac anesthesiologist. I support clinical research and development here at Butterfly. Peter, I'll let you introduce yourself to the group.
Hey, everybody, Peter Weimersheimer. I'm an emergency physician. I support education and clinical implementation of point-of-care ultrasound. And thanks for coming here.
And I'm John Martin. I'm the vascular surgeon and the chief medical officer of Butterfly, and I get to work with my two esteemed colleagues and learn from them every day.
Great. Thanks again, guys. And again, encourage our audience to please ask any questions in the chat as we go through this. This is going to be a whirlwind because we're going to, what started off as the top 10 articles kind of blossomed a little bit. We try to still keep the reins on it, but again, there was a lot of activities in 2024 with our technology. And so, but we try to bucket these activities into the following three here. One, on the topic of point-of-care ultrasound education, then talking about expansion into new markets and finding new specialties that are using point-of-care ultrasound and the clinical and economic impact those projects are showing. And then finally finishing off with what the technology advancements are occurring today, showing pointing to the future, where we see point-of-care ultrasound going. And with all of this, before we kind of go into these dives on these studies, I do want to we took a perspective of really trying to identify projects that are very pragmatic and real world, trying to empower. We're not looking anymore at the idea of, hey, a specific research study that has a very tight, inclusion, exclusion criteria, because the evidence out there for the vast majority of pathologies is well versed and into the literature of showing the value of point-of-care ultrasound. But still today, we need to talk about strategies for getting it to the masses, both on the education side as well as showing the clinical utility. And so that, I think, was a strong lens of how we identified some of these articles and news with our technology, because it was a key focus of Butterfly in 2024. So with that, I'll jump into our first project. On that note of education, right, trying to show how can we leverage new technology, specifically online learning, to be able to provide a starting point for students, both medical students and resident physicians, on embracing the concept of point-of-care ultrasound education. And this study started in Loyola, was evaluating the utility of radiology residents and medical students to develop their own self-directed point-of-care ultrasound curriculum and instructional videos. They leveraged Butterfly Academy And the neat thing about this was that this was completely self-guided ultrasound training. So these trainees went through our academy course, downloaded the online training modules, went through the test, had a hardware with our Butterfly IQ device, and with that, through no in-person instruction, they were able to show a high rate of satisfaction for the Butterfly system as a training tool, but also their ability in improving their POCUS skills in understanding anatomy and conceptualization of studies. The med students actually improved their anatomy scores, just through this online curriculum. And the participants really valued the fact that this was very user-friendly, using a highly portable device. And again, it allowed the ability to show that we know, training environment is a busy time, right? But by providing this self-guided kind of in-person, without an in-person mandated designated time to do the training, people can feel empowered to start their point-of-care ultrasound journey just, again, with a probe and some online material. And so I think really exciting study to show the possibility of scalability, and how self-directed ultrasound training is going in the future. Peter, do you have any additional thoughts here?
Yeah, I think as we go through some of these studies in education, what are the common barriers in medical education? Or one is access to equipment. And so really, really nice that this was a way that students and radiology residents could have access to a scanning device to practice. And the second is frankly, is the availability of teachers and faculty, and the traditional model of always having a bedside instructor is something which is important, and it's certainly important to have a curriculum where there's milestones and assessment of skills. But this was an effort self-generated by students who really wanted this to be able to have some of the access and some of the learning that they would like, separate from having some of those pressures in the educational space. So a really nice way to explore different solutions for that challenge.
So where we stand
Yeah.
today as 2023 kind of comes to a close, 24 comes to a close, as you're looking at the future, what percentage of medical schools are we looking at now where point of care ultrasound is part of the standard curriculum? And is there a tendency toward it being just the clinical years, or is it now all four? Where have we changed in 24 compared to the past?
Well, the more recent studies on that are probably delayed, but I think in the States, there's around 70% of schools now have some sort of POCUS programs. Majority of those are still in the basic sciences, and one of the challenges, which is maybe starts addressing, is going from the basic sciences towards the clinical clerkships and externships, where it's much more complex about how to have an instructor for different educational cadences, or whether there isn't a faculty member available to teach. So that's about where things are right now.
And
Certainly makes
John,
the
that's
studies important then.
absolutely right. I think it's a great segue into this next study, right? Where on that point, this project was an effort started by a group of medical students in a rural medical education medical school satellite clinic in Idaho. This group of students saw the discrepancy in point-of-care ultrasound experience and training, compared to where they were versus the other campuses that had potentially more resources. And they took a grassroots initiative to develop their own training strategy. And John, to your point about the fact of integration, across medical school years and into the clinical, Peter, to your point, what this model showed with first year medical students is that they leveraged not only online but direct connectivity with TeleGuidance connectivity, right? So the idea of being able to now, yes, you can have your online training, you can do some self-directed, but let's remotely connect you with a trainer who to be able to provide you sort of real-time guidance, whether they don't have to necessarily drive to that location, or the student has to drive to trainer's location. They can actually do this through just remote connectivity with TeleGuidance integrated into the app. And that was proven to be a very effective way of being able to improve fund of knowledge, image acquisition skills, ability to apply clinical contact in real world situations. Again, I keep going to the fact that it was really neat to show these different models. Not only did they improve their point of care ultrasound skills, but just their overall medical school training, their anatomy scores did better, with these, with the groups that got this sort of training, which I think is a point to the fact that when you have that engagement and provide new avenues of being able to incorporate point-of-care ultrasound, you overall improve the knowledge of medical school through medical school, with that integration. And so, again, another model of showing the value, but not having to do in person, but using teleguidance connectivity. And I think it's a great way, again, of showing about how we're using technology to be able to demonstrate a scalable solution.
There's a great question in the Q&A, which I absolutely love, since since Peter and I are one of these. We'll give Devinder being a little bit younger than us, but any suggestions
I'll take
to bring down the resistance for old attendings to participate in POCUS training? They've been successful with their students and residents, but not with the attendings. Too, quote, busy to learn.
I can take exception just as an older attending, but one of the things, and we'll talk about this in some of the studies we'll even talk about today, one of the ways that you can overcome resistance is through creative initiatives like this one, where there's a core group of attendings, for instance, who are helping with this teleguidance, and they offload the challenge for those students who in their own practice space, where the attendings at that space may not be as skilled at ultrasound or may not be able to even do the teaching which they would like to. And it winds up being a bit of a shared learning experience over time, where if that pressure is offloaded from those attendings, the students still get to learn, but there winds up being in some descriptions of programs where the students now can be a little bit of the teacher for the attendings. The attendings have years and years of experience of other medical skill sets that they can that they are teaching, but now there's ultrasound, which the goal is to learn, and how to do that can be dependent on having a curriculum with some remote support from a few faculty members. One thing that also happened in Indiana University, where the same curriculum used for the medical student has been adopted out towards residents, and actually adopted out in a CME format for faculty. So a really creative way to start enlisting faculty to start learning and becoming enthusiastic, and then become mentors for the next generation.
Peter, I think, two comments there on, one, the route of, CME is a great way of connecting to post-training faculty, and many academic institutions now will grant the ability for CME through these internal programs that are already developed, to your point, like the example you talked about Indiana. And I think we'll later on go into the study of one institutional deployment of Butterfly, right? And look forward to getting your insights on that study and how, the ability of getting a wide group of providers with different levels of skill. What was the approach to implement point-of-care ultrasound to, a variety of specialties and things? And often, right, it's starting somewhere focused, right? Figuring out what that gateway item is to get people engaged, that they can find approachable. My particular opinion is lung ultrasound is a great gateway to being able to incorporate people into seeing the value of point-of-care ultrasound. But we'll get there here. We got some more studies to go through.
Yeah, I'll save my answer for a little bit later, because I know you got a couple more ones, but I've got another suggestion for us, but we'll get that one later.
All right. Just including this quote, I thought this quote from the article was really interesting by one of the students, saying where they actually commented on the value of teleguidance, basically forcing them to really have to learn how to do the exam, versus when you're in an in-person environment and you see your your attending or your educator do the probe and manipulate it, and they may even have their hand on your hand to be able to show them. You don't necessarily have the same level of training, because of the fact that on teleguidance you have to kind of figure it's just you, right? It's just your hand doing the work. So interesting perspective. Comparing virtual versus in person, I think this is kind of the next step, right? So what if a head-to-head comparison of a cart-based in-person training program to a virtual training program for a specific type of ultrasound exam, the EFAS exam? This study showed at least that virtual does hold its own, right? Like it does show an ability to be able to provide a sufficient level of training for at least the EFAS exam for this group of trainees in pediatric residency. And again, all of these studies, I think, just point out the fact that technology is here to help, right? Really showing the value of, we have to think of new strategies. Peter, you already talked about the fact that one of the biggest barriers we know to point-of-care ultrasound adoption is the availability to education, right? And so the key takeaways that we've shown through all of these articles so far is how we can leverage technology to really try to decrease that burden. Any other insights from this one, Peter?
No, yeah, I think it's a great summary. Again, the idea is that if you are only dependent on trying to do a certain type of learning model, especially in a medical education space where there's a lot of learners and there's a lot of moving parts, that can really hamper development of a successful curriculum. So the idea that you can have some other ways to do training which offloads some of those pressures and is successful is fantastic.
Yeah, and I know I'm not monitoring the chat as much as you guys are, and by no means am I saying that we're at the stage where virtual is the end all be all, right? Nobody is saying that, but I do want to say that the idea of having to wait, right, for an in-person event or to find your, the person who's proficient at POCUS for you to get started. I think now more and more evidence shows that there's strategies, right, for you to be able to get started through online content, through these our TeleGuidance platform, and get to a level of proficiency. And we'll get into our AI training tool, ScanLab, in a little bit. But to get yourself to a higher level of proficiency, so that when you do get to those in-person training events, you just get so much more out of them, right? So I really think the two are not meant to replace each other, right? There's just a lot of synergy that can happen when you integrate both. All right. An area when, again, in the education lens of great to show technology being used on the front end of getting people exposure to learning a concept and showing that initial improvement in fund of knowledge. But what about durability of knowledge, right? We know that the ability to keep somebody at a level of proficiency 6 months out after receiving that training is difficult, especially if it's infrequent when that clinician is potentially doing those exams. So this was an effort to try to satisfy that gap and trying to show a way to be able to empower people to retain that level of proficiency even long after the in-person training event. So this is with our global health team throughout different regions, including South Africa, where post a 4-day training in-person event where assurance was made after that 4-person training event in which the training level for the practitioners was deemed to be adequate for them to go out and do clinical acquisition. They followed up for evaluating how they could retain that fund of knowledge for lung ultrasound through a web-based assessment tool. And so what happened is these providers, after that in-person training event, retained their exposure by getting a web-based environment where they had to continually upload images, had to review online content, and then they were tested 6 months after that in-person training event, and they were able to show no degradation in their fund of knowledge, which I think is an exciting effort to be able to show a strategy of how you can, again, leverage technology to retain that durability of training, especially in sort of these lower socioeconomic standards where it's very hard, or rural settings where it's very hard to ensure someone can constantly get that exposure to in-person training.
So
Yeah, I think this
how
ties
much
in
do you
really
think
well.
this was, I'm sorry, Peter, was related to the fact that it's lung ultrasound, which may be one of the easier skills actually to learn and can be learned quickly versus, say, cardiac or maybe more complex stuff like the spleen, for instance, or left kidney, or some of the more complex MSK stuff?
I mean, I'll jump in here, John. I agree with you that there's definitely lung ultrasound being one of the point-of-care ultrasound areas that are easier to learn and easier to retain knowledge. But the neat thing about lung ultrasound in particular is that that's still an incredibly impactful point-of-care ultrasound exam. In fact, I would actually honestly say, at least in my clinical care, I've had the most impact on patient management with lung ultrasound versus cardiac imaging versus abdominal imaging. And so the fact that this was able to show a value in that lung ultrasound space is exciting just in itself. But your point is very valid that there are other exams that are harder to do, and we have to kind of think of strategies to be able to meet the person for their needs using technology, or maybe incorporating other components of in-person training and figuring this out. So it's all part of a journey that you have to tailor to the needs of that group and those clinician base.
Yeah, I think this is a part of one of the challenges of medical education, and I use this term often, that you can have something that's taught as an exception versus something which is taught as a norm. And the idea that you can train somebody in a hands-on session at ultrasound doesn't guarantee that it's going to be adopted and used effectively in patient care. So this is a great study that shows that there's creative ways to try and enhance that. Not only can there be learning initially, but there could be maintenance of skills and use of those skills downstream. And I think to the point of lung being incredibly easier, not necessarily easy, um, relative to something like cardiac or something that's more complex. This concept that you have to start somewhere, and ultrasound at some level of any application is learning how to scan. And so for a user base, and this is something probably for future study, but for a user base to become proficient at some of the basic applications is classically thought of as the nice for that same user base to start expanding their skill set, to become more adept at other applications that are slightly more complex. And so here's a group of learners who had some hands-on training and then were able to master that skill set and adopt that skill set longitudinally with that web-based support. And so this would be the user group that I would argue would be ready for the next application and adopt that as well with support from their web-based support.
That's a great point, Peter. All right. So, Peter, I'll let you kind of talk about this effort because I know it's been a labor of love getting this off the ground, but exciting initial preliminary results here.
Yeah, so this is another way to try and have some creativity in medical education to support a small group of faculty or instructors have an impact on a large group of learners in an effective strategy. So, Kansas City University, there's essentially one course director and some of his assistants who are skilled at training, and they have some hands-on cadences, they have some didactics that are asynchronous. But ultimately, the idea here was to take that basic construct and use an AI-assisted application, our Butterfly ScanLab, for students to have their own probes to be able to scan, and when they could, and use that AI-assisted application to start practicing their ultrasound skills. And on top of that, then was the cadence of if you're just having students scan over and over again without any feedback on their scans other than they're trying to master what they're seeing on the AI, uh, is it more effective to actually offer some asynchronous feedback as well? So on top of this now, there's the basic core of the curriculum, there's the ScanLab instruction, and now there's sonographers and clinicians who are offering structured feedback to those students as they do their ScanLab cadences. So really evaluating how much learning can happen by doing a lot of asynchronous practice by students with a little more asynchronous feedback. So very little hands-on or required instructor to student activity past that initial engagement. And so far, to be published and to come out next year, so far, really impressive how students are evolving from, let's say, an average score of 3 and a QA score to having 5s, where they're really truly mastering EFAS and lung and cardiac. Again, cardiac, a complex scanning cognition that they're doing really well by using ScanLab and using that asynchronous feedback.
Peter, really exciting. So just so I understand it again, I'll keep going back here. This effort was students would, after their in-person training event, would then go to a set of metrics of where they would use the ScanLab AI training tool to be able to get their own images. And then the real interactivity was after they got those images, they were reviewed by an expert and provided feedback. And then the trainee would use that feedback to go back and then get another set of images. And that's what you're saying is improving their level of skill, is not so much from more frequent in-person training events. It's kind of just repeated feedback sessions of using the ScanLab tool for cardiac, lung, and abdominal.
Right. It's the cadence of a small group of instructors who have a large number of students they're trying to start getting trained and enthusiastic about point of care in the clinical space. And this is basic training prior to clinical clerkship and externship. But the students are taking an AI assistant app and scanning amongst themselves, and just from that itself, developing their skills as was the app was designed to do effectively. But then also on top of that, getting expert feedback to be able to harness the feedback as they practice amongst themselves to really hone their skills. And so that cadence of the educational app plus feedback to advance skills again and practice from the tricks of the trade that they get taught on the asynchronous feedback to really become very proficient at scanning. And then this will be translated going forward into the clinical clerkships and externships, where students will have, they all have their own probe, so they can now go into the externships and clerkships and now have scanning where that same feedback comes back to them, but this time on live patients, essentially.
So Devinder, you brought up the point, and we discussed a little bit of how do you get the older physicians, and I think it's going to have to be a combination of things. The data is now very clear that if you practice point-of-care ultrasound, you deliver better medicine. It's more efficient, it's more accurate, it's more cost-effective, it has higher patient satisfaction. So candidly, anybody that's not practicing POCUS is behind and actually not practicing at the state of art. Now, that may be heresy to some, but the data is overwhelmingly convincing to show that. So I think it's going to take a combination of peer pressure, of students coming from below, and from mandates from institutions that say, thou shalt do this because it's better medicine and it's more cost effective. And when you look across the country, when about 48% of institutions are now underwater when it comes to the margins at their institution, and overwhelming data say that this is more cost effective, you're kind of hard pressed to say people can just get away with not practicing the best medicine. And I always believe we take an oath to practice medicine to give our patients the best care humanly possible. And candidly, anything less than learning this, to be honest, and I know people probably get mad at me for saying, you're just being lazy. You need to go learn this because it is better medicine.
Well, I completely agree. And thanks for being blunt. This is 2024 clinical care, is to have this technology in your pocket instead of a stethoscope, frankly. But what's really exciting about some of these articles, and some more of the articles we'll talk about, is that for those who have been, for whatever barrier, have not learned, and part of it is a barrier of how do I learn, and who can teach me, where can I get the education, that there are now all these alternative models to support that asynchronous learning, that someone who has not been in a medical education ultrasound program or not been in ultrasound residency, they can actually start picking it up and practicing at the 2024 standard.
Well said, Peter and John. Your points. I think obviously the three of us are drinking this Kool-Aid, but it's not Kool-Aid anymore, right? It's water. It's what we all should be doing. But what we've spent the time so far talking about is those strategies of how, in a real world environment, we're getting these stories of how people are figuring this out, how people are actually learning how to incorporate training, education, without requiring a plethora of resources and dedicated, clinician time. Again, leveraging technology to help meet people where their needs are and embracing the topic. But let's continue the conversation on just that metric, right? On, again, John, you said it so well, that the world does not need another randomized control trial comparing strict inclusion criteria, exclusion criteria, patient population, comparing standard of care without ultrasound and ultrasound, the potential benefit, right? It's been shown thousands of times over for a variety of pathologies and care settings, but the evidence is still lacking in the space of, okay, great, how do we incorporate this pragmatically, and what does it do in terms of moving the needle in that sort of real world environment? And that's where I'd like to segue into, is some of these projects that we took off in 2024 to really try to show some data in that space, right? Again, not outside of sort of the pure research world, but really trying to be pragmatic about it. The first effort, I think is a great starting point. We know primary care is an emerging area for point-of-care ultrasound adoption. New requirements for family medicine residency require that point-of-care ultrasound is an integrated part of residency training. But how does it play out in a real-world environment in an outpatient clinic with a provider in terms of embracing point-of-care ultrasound? And what do the numbers look like to justify implementing a point-of-care ultrasound workflow? And so this abstract that was presented at this past FMX meeting, I think really kind of highlights that walkthrough of where Dr. Stephen Erickson, who's been a great partner with Butterfly and in the topic of point-of-care ultrasound, just documented for a year implementing point-of-care ultrasound into his workflow. He's a rural family medicine physician who sees everybody from from birth to death across a variety of clinical situations. He implemented point-of-care ultrasound, did a variety of exam types: cardiac, obstetrical, pulmonary, MSK, DVT, and we just wanted to try to. And he documented through those exams, implementing a workflow that allowed him to generate a report, generate a billing strategy for those reports, and what were the cost effectiveness of doing that. And I think it's really neat that this telltale for this single clinic environment with a limited number of exams. So again, over a year, doing a total of 282 exams, the net revenue in terms of the reimbursement model in that care setting still proved to be very positive for embracing point-of-care ultrasound, right? So it wasn't such that they had to do, Dr. Erickson and team had to do a plethora of ultrasound exams every day, doing every single patient, but rather implementing it in a strategy that I think is much more sort of manageable and approachable to this care setting. Just 282 exams in that year, the results showed that average revenue per exam, $41. These were reimbursed exams. It paid for the system itself, plus then some, just within a year. And again, that's just the financial numbers, right? We're not even talking about the clinical benefit of the fact of decreased consultations, the improvement to patient care by the patient now being empowered with knowing what's going on rather than having to wait for a specialist or a formal study, right? So I think a great starting point to talk about pragmatic real world evidence.
And
Peter, additional
Dr.
thoughts?
Erickson
Yeah.
is on. So,
Oh,
Stephen,
great.
great to
Steve,
have
if you're
you.
on, we'd love to get your comments
Yeah,
here.
give your 2 cents about the study and how it really is transformative in terms of showing how not
Yeah,
much scanning has a lot of benefit, and especially love the concept that you have rural patients who have reduced referrals and reduced testing and the challenges in that environment of what that means for them. So thanks for
yeah,
hopping on.
yeah. Thanks, Peter and Devinder. Yeah, I gathered this data and shared it just to show that insurance companies pay for it if you document it correctly. Um, and you're not going to get filthy rich by doing POCUS, but you are going to make money, not lose money. And the downstream effects are something I didn't have time or resources to study, but my gosh, a $41 DVT exam versus when I used to send people to the emergency room and then they got a $2,000 workup to see if they had a DVT. This is just, you know, this is a no-brainer that this is the right thing to do in primary care.
Yeah, and for those of you who are listening who may not be in the American payer system where it's fee for service, again, that just even the cadence of being able to do that DVT study at the office, have that doctor-patient relationship where you're showing your patient yes or no, they do have it as they came with that concern, and they don't need to drive to the emergency department and they don't need to drive someplace else, and they can have that satisfaction of working with you, Steve, as their clinician to have an answer that really makes a difference in their life, which is so the billing, the return on investment in our system is a benefit, but there's this so much more benefit from the health economics and the personal economics of how we do healthcare with point of care.
Stephen,
Really
were there any
fantastic.
particular studies where you found denials popped up? I know you had a significant number of denials in there. Was it a particular use case or study that popped up more than others?
Yeah, the challenge for us is being a rural health clinic. There are some kind of unique rules about how we get paid. So Medicare was some of our Medicare payers would just kind of flat out say, yeah, that's an ancillary service. It's not paid for as part of a rural health clinic visit. But any private insurance, it was almost always covered. Medicaid, TRICARE, those things were all usually well reimbursed.
That's great. Well, obviously you have a unique practice there. I know actually, having been actually down visiting a couple senators actually just yesterday, there's a lot of discussions around changing a lot of the payment models in rural healthcare America because there's a desperate need for that. So I think you're getting people's attention about the uniqueness of your practice and how there needs to be more financial support because too many of these rural hospitals are actually closing. And so I think there's a recognition of these kind of things. So maybe we'll see in the future denials to be significantly less. It's kind of unfair for a particular patient or even you as a physician where it's paid for by what for one patient, exact same use case, exact same problem, and not paid for by another. It kind of shows you the inconsistencies that we have across our healthcare system.
Right. Yeah. But the $41 per exam was calculated including the denials. So, you know, I would walk into the room not knowing whether I was going to get paid or not. But on average, 3/4 of the time I did. And when you average it all out, it was an extra $41 in addition to my usual charge for the clinic visit.
That's fantastic. This is a really important study. I think this needs to be shared and shared widely. That shows that it makes sense because at the end of the day, we all have a mission, but if there's no margin, there's no mission. So you've added fuel to the fire as to why people should do this.
We have a question from Ahmed, and the question is about any studies in the use of IQ Butterfly in vascular, cardiac, and renal. I'll do a quick answer. You might want everyone can jump in. I think the important thing about whether it's Butterfly IQ or another point of care system is that in the point of care space, there's absolute use for using ultrasound in vascular, cardiac, or renal. So looking for, is there a DVT? Is there an arterial obstruction? Basic cardiac function, pericardial effusion, things that you can make decisions on with really yes/no questions. Renal, is there hydronephrosis or not for someone who has flank pain? So all of those use cases are phenomenal in the point of care space. And remembering that point of care, the goal is to identify a yes/no problem and use the imaging you have at the bedside to answer the question, and may lead to having a higher level. You know, maybe the person needs a comprehensive echo. Maybe they need a mass protocol renal CT scan if there's a concern about something like that. But absolutely, the butterfly probe is fantastic for just pulling out of your pocket and starting the journey of answering specific questions about the patient in front of you.
Peter, I echo your thoughts, and Dr. Erickson, thank you for joining. Steve, we really appreciate your insights, and I'll just echo what John said about the fact that this is you lay the groundwork here with this evidence, right? And we look forward to seeing this blossom across primary care to really show that, you know, this is an approachable, and just hearing you talk about it, right? You make it, the way you describe it makes it an approachable area. So, you know, I think all three of us really appreciate, you know, you being on the cutting edge of this and look forward for you to bring the masses to it here in the coming years. All right, now I think this is an article that I think we're all excited to talk about because, you know, Peter and John, there is this constant way of how we define ultrasound imaging with image quality, right? You know, people do this in terms of comparing different handheld devices, different cart systems about, oh, how well does the nerve look in this picture? How well does the heart look in this picture, right? And a way of how we always kind of look at it as a way of comparison. But the reality is, like, has anyone really looked at the ability for it to actually make your ability to diagnose pathology and make treatment decisions, right? And I think this study is very exciting because of the fact that it points to the fact of, if you just compare with the question not being about image quality, but about diagnostic accuracy, and comparing a handheld device, our butterfly system, to a cart-based system, looking at cardiac, lung, biliary, renal, abdominal aortic imaging, does handheld answer the question that you need to be answered in terms of being able to come to a diagnosis? And the results of this study, I think, really very strongly positively say yes, right? The fact that you can actually use handheld ultrasound to be able to answer the wide variety of pathologies listed here to a very high level of sensitivity and specificity that is comparable to CART systems, right? There was no significant difference across any of these presets. In fact, some actually showed a little bit of potential improvement with the handheld device. And Peter, and I know you know this is your space in the sense of what a care setting in which the ability and portability and having something in your hand to be able to quickly do an assessment for a diagnosis means everything versus going out and getting that cart, right? And so I think really exciting study to kind of show when you look at that question of how does it perform for the ability to make a diagnosis, really not a difference when it comes to handheld versus cart.
Yeah, I love this study, right? Because first of all, they're using a first generation. They're using a probe that was 8 years old. We have the third generation probe, which is just fantastic. But it doesn't talk in this, as it's presented in this abstract. Everyone who has been involved with cart-based sonography understands that a lot of places can't afford to have them, and that's been a limitation. But when you have them, you have to make a decision to get them. And the whole ability to just pull a probe out and ask the question at the bedside without thinking, do I need to go get the probe, the cart? Is it unplugged? Is the battery dead? Is it covered in gel and I have to clean it off? And then I can get the same yes, no decision-making answer is just wonderful. I think for those of us who practice in the handheld space, it's a breath of fresh air to be able to walk in a room and just do your job. So really nice study to offload a little bit of that constant pressure of, well, I need the bigger system, I need the better imaging. And certainly there are things that happen in even the point of care space that an advanced cart with different features, transesophageal echo, et cetera, is not replaced by a handheld, but 90%, 95% of the time, this study is an example of you can answer the question at hand and move on.
Yeah, so I mean, I think very positive and exciting results with maybe hopefully kind of changing the story a little bit, right? About it's not so much just focus on image quality, but really on its ability to make a diagnosis, right? And so, you know, exciting results here. Well, let's talk about another effort that I think talks to the emergence of point-of-care ultrasound to new care settings, right? The EMS space is an area we just had our last month's webinar, right, on the value of point-of-care ultrasound for the EMS space. This article, I think, really kind of highlights that value story, where where a institution, Indiana University, took on the effort of saying we need to improve the quality of care for heart failure when patients come into the emergency room. We know this is a huge problem here in the US and abroad on the management of acute heart failure exacerbations, and time to diagnosis and time to appropriate treatment make a big difference on the ability of getting somebody, you know, to the right area of care. And this study showed that with a very limited experience of training, EMS providers, just a simple less than hour training session to walk through lung ultrasound, empowered these paramedics to be able to go out and perform lung ultrasound exams. And when they did that, they were able to dramatically improve their sensitivity and specificity for detecting if somebody was having a heart failure exacerbation through detecting fluid overload or pulmonary congestion versus not. And when you implemented that ability to make that improved sensitivity and specificity, it decreased the time to treatment dramatically, over an 87% reduction in time to treatment, because now you're empowering those paramedics to be able to come more definitively to the diagnosis. That gets relayed to the emergency care environment to be able to, again, more streamline the ability to care for this patient population that we all know is incredibly sick and are always walking that balance rope of, you know, getting overloaded and having to require intubation to being in a state where they're, you know, somewhat, you know, able to stay out of the hospital. So with this, I think really positive sign to show an emerging area of EMS and the value of lung ultrasound. John, Peter, any other additional thoughts on this one?
This one's just a home run. I love this study. And I think if you've ever been in an emergency room and know what it's like as a patient, sitting there for 2 hours before they even start treatment is pure absolute misery, and particularly if you're struggling to breathe. So this is another one of those studies I look at and say, how can you possibly, in good conscience, not have a point-of-care ultrasound device on an ambulance? I just don't understand why when you see this data. And I think this will be repeated over and over again. I can tell you in my own county, I took this study, went to our EMS units, and they said, okay, we're on. And Peter will be coming into town beginning of January. We're training both the city and the county. And as I said to them, if I get short of breath, I want you to have one of these on the ambulance and use it, because it's just remarkable, this data. And I think, and it's not just lung, obviously, where point-of-care ultrasound is helpful on EMS, but this is a really important one. So I think this is great data, and I certainly would encourage all of our listeners, print this bad boy out, grab it with you, go to your local EMS guys and get them loaded up on point-of-care ultrasound on their buses.
Yep, this is on the 2024 Mount Rushmore of studies.
That's right.
Right.
Yeah. Love it.
Again, I think it's super crucial to understand is at the beginning where they say without ultrasound, the sensitivity and specificity of clinical exam alone. And this is data that we've known for years on lung studies, that lung is great for distinguishing between wet and dry respiratory distress. And here are medics who have an hour of training who change their ability to manage patients in the field from I don't know, right? Sensitivity of 23%, that means that's worse than guessing. I don't know to I know what's going on. I'm going to start that treatment cadence. And to John's point, hanging out with air hunger and respiratory distress and waiting for relief is just agonizing. And what a great study that documents that minimal training, responsible training, changes the entire cadence of not sure why, sir, ma'am, you're short of breath, to I get this, and we're going to start managing this effectively ASAP.
Well said. It almost bears repeating one more time on the value of lung ultrasound and differentiating that, right? Because externally, the patient will look exactly the same. They'll look like they're in respiratory distress, fatigue, short of breath, but it's only until you can look inside that you can determine what the real mechanism is, right? And lung ultrasound is an incredibly effective way to do it.
Wheezing is just that.
Exactly. On that note, let's continue the journey of now, okay, that's heart failure population. Again, we already talked about the fact that heart failure, #1 incidence of hospital admissions for patients over 65, #1 mission for readmissions for patients over 65. It is an ever-growing problem, both in US and abroad. We know it costs hospitals lots of resources, both clinical resources as well as costs associated with the potential complications and length of stay. What happens if you embrace the idea of point-of-care ultrasound for the clinician type that are taking care of ward-based CHF patients? And so this is fundamentally here in the United States, hospitalists, so physicians who have internal medicine training, primarily hospital physicians who are in charge of managing the admitted CHF patient. What if you incorporate point-of-care ultrasound, again, not as a research study, but as a new standard of care, where you implement a training program and you deploy it in a manner that says, okay, you're going to incorporate daily point-of-care ultrasound now that you're proficient at it into your daily assessments of the patient, of these CHF patients. How does it impact the ability of care, the quality of care you're able to provide? This preliminary results that were just presented, John, you were in Berlin just a few days ago talking about this presentation here with an institution here in the Northeast, Robert Wood Johnson Hospital. This partnership showed that with that deployment over a year on a patient, on total of just over 200 patients, when you implement point-of-care ultrasound versus the group that received POCUS versus the group that didn't receive POCUS by their providers, dramatic reduction in length of stay, both for the lower severity CHF population as well as the higher severity CHF population, net over a median of a reduction in 4 days on average. Cost savings dramatically in terms of cost savings here because of, again, a lot more detail to unwrap here, but preliminary through the abstract showing significant 50% reduction for that lower severity group, going from 500K to 250K, from an almost $1 million reduction for the higher severity group. And the results, when you look at this, it's so eye-opening. You just kind of are compelled to relook at the numbers because it's almost unbelievable. But it shows the value again of when you implement a tool that allows them on a daily basis using parameters that are real time, right? Lung ultrasound is a real-time ability to detect congestion status that moment. There's no lag compared to like a chest X-ray and things like that. You have a more real-time assessment on your patient population, in addition to vascular and cardiac assessments to integrate into the entirety of your assessment. These are the potential results you can see, right? And so I mean, I love talking about this, but I mean, it's something that is, I think, very exciting to talk about when you implement this in this care strategy to a provider group that is still emerging on their adoption of point-of-care ultrasound. Hopefully, this project and effort will really kind of hit that ground and to that specialty show the value of embracing point-of-care ultrasound. John, I'll leave any other thoughts, as I know you were just with this group just a few days ago.
You know, the most interesting thing about this study to me was the results were so dramatic. They almost border on unbelievable when you saw the amount of money that was saved. So literally, we went back multiple times to validate the actual numbers because it was so staggering. But I'm not so sure why it should have been so surprising, because we know how bad chest X-rays are. We know what the care is like inside a hospital and the length of stay is for these people. It shouldn't really surprise us. But what's really great is now we have objective data. And again, this is another one. And what makes this year so important is there's real objective data to say, okay, here's a mandate. Now, why do we all use electronic medical records? Because we were mandated that, and that first you got paid and after that you got penalized. Well, guess what, folks? If you're not using point-of-care ultrasound for the management of your heart failure patients, you're being penalized. So, and you're being penalized a lot. So this is another one that if you're an administrator, you look at it and go, okay, I need my team trained. I need them to have devices. We need to manage heart failure patients like this going forward, because I'm paying a pretty huge penalty. And this is not hundreds of dollars. It's not thousands of dollars. It's millions of dollars saved. And it wasn't that big a group in which this much money was saved. It represented a fraction of the patients in their institution. So again, another one of these really important studies that were published this year that gives the economic data that supports the clinical information that we've had all along.
And a very small part of the study, which I think is profound, as we were talking about education earlier, was the fact that the providers who were doing this study had so much power in identifying normal, right? So we talk about scanning and how to learn and how to become accomplished at using ultrasound in clinical medicine. Just seeing a normal and offloading the pressure of that was profound for these providers, separate from interpreting what do I do with a positive study. So that cadence as a learning pathway is really profound to read about in the study.
No, Peter, thanks for bringing it up. And again, look forward to getting this manuscript out next year. All right, moving along here about the value of institutional deployment, right? The idea of a massive institution taking on the ability of embracing point-of-care ultrasound. Peter, this has been, again, another labor of love of yours and John's to really try to get this off the ground, many, many years in the works. This publication kind of tried to capture all of those experiences and try to provide a playbook, but love to get your insights as you were key to this whole thing.
Well, I think this really builds on some of the comments that we've already made about if you're not doing this, you're behind. And this was an institution where at a leadership level that there was a decision that point-of-care ultrasound needs to be part of their standard of practice. And so they tackled it by doing really multifaceted, where number one is you have providers that you want to scan, for instance, in the primary care space, but they don't have access to devices, get them devices. Number two, there are providers who are scanning, but there was no integration of those images in the medical system. So for those images that have value in patient care and decision-making, and frankly, ROI, those need to be integrated. So they use a software solution to integrate handhelds and cart-based systems so that everybody who is scanning had those scans having value. And finally, tackled some of the challenges of governance, where if you're expecting providers to use ultrasound in clinical space, you have to support them getting trained. You have to make a decision on what does it mean to be a trained clinician, to be able to use ultrasound in clinical decision-making, and to tackle that whole part of governance that is so thorny, I think, in medical systems. If you want this to happen, it's not going to happen by accident. It has to happen with intent and with a commitment to supporting the cadence of that growth. And already some of what this publication was highlighting is that on this journey that they were starting to see both return in terms of revenue, but also in terms of patient outcomes. And so the goal ultimately was that everyone was using this for patient care, but have this as a positive experience to get there. So more to come, but just certainly an example that this can be done at any institutional level if there's a willingness to have ultrasound be what it should be as a care standard in 2024.
I think
Yeah.
one of the big highlights of this study was and within the paper itself is a great structure for your program. And it goes through each of the individual elements. And it also tracks for you, what does it look like when you're at your infancy and what does a mature program look like? So it's a great guide that you can bring back to your institution and then begin to set your whole program up from. And I think what the really nice thing, this was led by Mike Rotundo and Dr. Waldman, who happened to be a radiologist driving this. For all of you that struggle with radiologists supporting this, he was a radiologist that is driving this program. They had the motto from the big, we're going to go big or go home. And they said, we're going to go swim in the deep end of the pool and we're going to train everybody in the organization to do this. And they're on a journey, really. If you think about that, 2,500 ultrasound devices across the system, a lot of ultrasound devices, a lot of images, but also a lot better care than what they were doing before they did this. So this is a really impressive effort by this institution. And the first people out doing something are definitely the leaders. The movement doesn't start, however, till the second, third, and fourth ones are coming. So we're looking forward to that in 2025 of them following the Rochester blueprint and seeing others go big and go home and start to consolidate their stuff with the combination of devices, education, structure, and having the software and middleware so that you can track these studies throughout the entire system.
Excellent summary, Peter and John. Excellent insights. I think, the title says it best, right? Like that. I really love this publication because of that. It really does provide that roadmap for people to leverage. All right. I know we're getting on to time. Peter and John, how are we doing on the chat and QA?
We're good.
We're good. All right. I will do a whirlwind for technology advancements because this could be its own webinar in itself, right? So I just want to kind of give some highlights as we talk about this. The world of advanced technology advancement leading to image improvement in terms of just the ability to get a cleaner image through, for example, with here at Butterfly innovations with our chip-based ultrasound technology, it is always a lane that's going to be there. And it's so exciting to see year after year after year how that continues to improve, how things get more efficient, more portable, with higher level of quality. The addition of the space of AI, not only helping with image guidance and what we talked about earlier for improving the ability to get a trainer to a higher level of proficiency or facilitating their training, there's also now a lot of space going into helping with analysis and image interpretation. I'll just kind of try to highlight that. And again, this whirlwind 1 minute. One is around aortic stenosis, right? We know aortic stenosis is a complicated disease process when it comes to quantifying it and identifying it with ultrasound. Traditionally, this has been thought of, maybe I'm, kind of maybe a little bit more traditional in this, but I would say it's been thought of as a more higher proficient level of training required to make a detection of aortic stenosis and quantify the severity of aortic stenosis, most often because it required sophisticated ultrasound scanning techniques. But through what this article is trying to show is that with the leveraging the new areas of machine learning and AI-enabled network analysis of thousands and thousands of ultrasound images with annotated pathology, there's ways to be able to detect aortic stenosis from a simple 2D image that show appropriate level of sensitivity and negative predictive value for you to be able to quickly answer the question, is this person at risk or has the disease, or do they not have the disease when it comes to aortic stenosis? And this is, again, just obtained from simple PLAX and PSAX views. You're able to develop technology that shows very high level of sensitivity. And so exciting to see. This is, again, in the research space, but look forward to seeing this come into, the development and future clinical care spaces as more and more of this evidence comes out. And I'll leverage that into the ability of now saying, well, what if patients could scan themselves and be able to leverage technology through guidance principles and using AI? There's data showing that as well about the ability of self-administrated lung ultrasound to be able to be done and performed at a high level of image quality in a patient population. These were COVID patients. Again, showing the feasibility of that new care setting space of patients being able to acquire the images themselves for interpretation. And finally, the work that we've talked about before on the value of what if you didn't even show the ultrasound image and you created AI technology that would allow you to just blindly obtain images through a blind sweep methodology, which is shown here on the right side. Are you able to then just use AI to make the analysis and interpretation? And this is, for obstetrical ultrasound for gestational age, showing the value and the ability and clinical performance of that AI tool to standard clinical measurements to be equivalent, in fact, in some gestational ages, to be higher performance with the AI tool. So all of this pointing to the fact that the future of AI integration into clinical interpretation is very, very strong, and really looking forward to seeing that future blossom here in 2025. I'll finish this. I know we're just past time, and we always try to stick to the hour. But John, you kind of said something like this earlier about when you were talking about the adoption at Rochester. But I thought this quote was very appropriate for the area of research and point-of-care ultrasound, where we're well past that stage of being ignored. We're well past the stage of being laughed at. We're still in that fight, I think, of showing this, and I think a lot of the evidence that we talked about today really shows how you can arm yourself to have that fight in an evidence-based manner. And we're getting closer and closer to winning this, so that world, John, that you talked about, where providers truly are empowered with the ability of handheld ultrasound, is coming, right? And with that, I'd like to thank both of my panelists for enjoying this call. I know I've always enjoyed having this year in review. It's a great reflection point for me to talk about all the exciting things that have happened here at Butterfly over the year. And looking forward to another great 2025 with both of you. And for our audience, thank you for listening, and feel free to reach out with additional questions. Peter and John, I'll let you end it as well.
Oh, that's great. Thank you very much. And we look forward from the feedback from you guys as well of what you're looking forward to, where we can actually help you, what projects you think would be important to advance this. And when you flip your institution, please let us know. We want to shout from the mountaintop that you have.
Yeah, thank you all. Thank you all for attending. And as you're all here interested in ultrasound, let's go and do this, right? The more everyone scans, the better we take care of patients. And it's a great community of POCUS enthusiasts trying to change the world. So please reach out with any questions, any ways we can be supportive. And happy scanning.
Happy scanning and happy holidays to everybody.
Happy holidays, everybody.
Happy holidays, yes. Okay.
All right.
Thank you for
Thanks, guys.
both of you. You okay, John? Oh,
It was good.
it was good. I was trying to have him be a little less verbal, but
2 questions. Do you have a list of articles that you included? We should send that from Mary Fran King. And is Butterfly still trying to help archive images separate from the cloud?
yes.
To archive, yes. Can you get that, Mary Fran King, Peter?
Yeah, I think this is all. Let me see how to do this.
I wonder if you can still type it in it now.
I don't know if she'll get it.
All right, so we'll copy your name down and see if we can find her from an email address.
Yeah, I think I'll take a screenshot here, and I can get it from Aaron.
Okay, all right, great. Nice job, everybody.
Yeah, thanks. Nice to see you.
It was fun.